Welcome to the deep dive. So you've handed us a pretty serious stack of research here, everything from neurobiology to clinical cardiology.
It's a lot, for sure.
It is, and our mission today is very, very focused. We are going to pull out every key concept, every piece of evidence you need to build a high-scoring exam essay.
And the prompt is a big one.
A huge one. The autonomic nervous system as the hidden driver of modern chronic illness.
Right. And that is an immense and I think incredibly critical topic, but it's also one that gets misunderstood a lot.
How so?
Well, for anyone new to this, the challenge isn't just learning the terms. The real task is weaving together a coherent story, one that links things like chronic stress, aging, and inflammation through this one single pathway that most people just ignore.
So we need to show the how, the mechanism.
We have to. We need to clearly define the physiological mechanism that fails before we can trace its impact on all these different diseases.
Exactly. We're aiming to give you the framework that shows this isn't just a bunch of random symptoms. It's a failure of the body's master regulator. So let's start at the absolute beginning. Let's set that foundation by defining our star player, the autonomic nervous system, or ANS.
Okay.
What exactly is the ANS? And, why don't we feel it working?
That's the whole point of it, really. It's designed to be the silent operating system running in the background. The sources define it as a critical subcomponent of your peripheral nervous system.
Okay, peripheral, so outside the brain and spinal cord.
Right. And its defining characteristic is that it regulates all the involuntary physiologic processes.
Involuntary, so everything that keeps you alive without you needing to consciously think about it?
Exactly. Your blood pressure, your heart rate, how fast you breathe, the movement of food through your digestive system. Even things like sweating or hormone release, it's all happening automatically.
So if I decide to pick up this mug, that's voluntary. That's my somatic nervous system.
Correct.
But if someone slams a door and my heart rate suddenly jumps?
That's the ANS. That's it, working beneath your conscious control, constantly monitoring and adjusting your internal state to keep you alive and stable.
Which is why it's so fundamental to health. Now, the sources break it down into three divisions.
Three distinct divisions, yeah. You got the two famous ones, the ones everyone's heard of, sympathetic and parasympathetic.
Right. But then there's this third one that I think often gets left out of the popular conversation.
It does, and it's a huge oversight. It's the enteric nervous system, or ENS.
The guts brain.
That's what they call it. And it really deserves a proper definition here, because its autonomy is just, well, it's astonishing. The research describes it as this huge web-like structure that's literally embedded in the walls of your gastrointestinal tract.
And it can work on its own?
Almost entirely independently of the central nervous system. Its main job, of course, is regulating digestive processes, motility, secretion, blood flow. But what really drives home its power is just the sheer number of neurons it has.
Okay, what are we talking?
Over 100 million neurons.
Wow, 100 million. Just in the gut.
Just in the gut. That's more than in your spinal cord. It's more than all the other peripheral ganglia combined. And that density, that complexity, it really underscores how vital and how delicate our gut functions are. It's managing this incredibly complex process locally on its own.
That's incredible. So it's not just a simple tube. It's an intelligent, semi-independent system.
A second brain is not an exaggeration. It's crucial for understanding that whole gut-brain connection we hear so much about.
Okay, so that sets the stage for the big two, the dynamic duo, the sympathetic and parasympathetic branches. It seems so easy to just label them, stress and calm.
Or good and bad.
Right. But the source material, it really hammers home that they're complementary partners. They're not enemies.
No, not at all. They're two sides of the same coin, and they're in this constant physiological dance to keep your body's internal environment stable.
So let's define them properly. Let's start with the sympathetic nervous system, the SNS.
The SNS is best understood as the gas pedal, or the classic term, the fight-or-flight response. Its whole function is mobilization.
Mobilization of what?
Of everything. It needs to rapidly access and deliver resources, stored energy, oxygen, and prepare the body for immediate, acute action when it perceives a threat.
And that threat could be anything from, a tiger in the bushes to a surprise deadline at work.
The body doesn't really distinguish, especially in the short term. Yeah. And the chemical signals for that mobilization are primarily the neurohormones, adrenaline or epinephrine, and norepinephrine.
And when those get released?
They flood the system. They're powerful signals to ramp everything up. Physiologically, as the sources detail, the effects are immediate. You get a surge in heart rate and breathing, your pupils dilate, and this is key. It represses less essential functions,
Like digestion.
like digestion, immune surveillance. Those can wait. The priority is breaking down glucose and fats for instant energy. It's all about survival in that acute moment.
Okay, so if that's the gas pedal, the mobilization system, then the parasympathetic nervous system, the PNS, has to be the recovery system.
Precisely. The PNS is the rest and digest system. I like to think of it as both the brake pedal and the maintenance crew.
The maintenance crew, that's good.
Yeah, its function is all about restoration and conserving energy. It manages the body's long-term resources, and it's primarily mediated by a different neurotransmitter, acetylcholine.
And acetylcholine is the chemical signal to
Wait, hold on. What? Slow down.
slow down, repair, and regain normalcy once the immediate stressor is gone.
And when we talk about the PNS, we have to talk about the vagus nerve. It seems to be the main highway for this whole recovery system.
It absolutely is. The vagus nerve is the main effector. That means it carries those rest and digest commands out from the brain to the organs in your chest and abdomen, the heart, the lungs, the gut.
So it's sending commands down.
It is, but here is where it gets really interesting, and this is a critical insight for your essay. The vast majority of the vagus nerve fibers, we're talking about 80%, are actually afferent. 80%. Wait a second. Afferent means they're sensory fibers. They're reporting information up to the brain, not carrying commands down.
Exactly. This completely changes how we should think about the gut-brain axis. It's not just a top-down control system. It's the body, specifically your internal organs, providing this continuous, crucial stream of feedback to the brain about what's going on inside.
That's called interoception, right?
That's interoception. The vagus nerve is less of a simple control wire and more of a two-way communication superhighway. It integrates the state of your viscera, your organs, directly into your emotional and cognitive processing in the brain.
Wow, that's a profound idea. It suggests the entire system is built to constantly listen and recalibrate itself. Which brings us to the ultimate goal, the healthy state, homeostasis.
Correct. Homeostasis is defined in the sources as that necessary dynamic balance between the SNS and the PNS. It's the state that maintains the organism's general healthy condition. It's not static, it's a constant process of tiny overcorrections back and forth.
And the key takeaway for the essay is that this balance is health.
Yes, balance is the healthy state. Chronic disruption of that balance, being constantly skewed to one side, that is the pathological problem we're investigating. That's the hidden driver.
Okay. To really understand the pathology, we have to first understand the harmony. So let's walk through this dual system in action. Let's start with maybe the most sensitive indicator of this balance, cardiovascular function.
The cardiovascular system is the textbook example of this dual control. The SNS, the sympathetic system, causes cardio acceleration. It speeds the heart up, makes it contract more forcefully.
And the PNS?
The PNS, acting through the vagus nerve, causes cardio deceleration. It slows the heart down. But what's really fascinating is that under normal resting conditions, it's the PNS that's dominant.
So your brake pedal is always lightly pressed.
That's a perfect way to put it. It keeps your resting heart rate lower than it would be otherwise. And that constant engagement, that vagal brake, is what gives the heart its flexibility and resilience.
And we can measure that flexibility. This brings us to a critical term for the essay, heart rate variability, or HRV. We need to define this one really clearly.
We do. HRV is a highly validated metric. A lot of people think your heart beats like a metronome. You know, if your heart rate is 60, it's a perfect 1-second interval between each beat.
That it's not.
It's not. Heart rate variability is the natural fluctuation in the beat-to-beat intervals measured in milliseconds.
So it's the tiny variations in time between each heartbeat.
Exactly. I like the analogy of driving. Your overall heart rate is your average speed on the highway. But HRV is the driver's ability to constantly make tiny adjustments, tapping the brake and the gas to maintain a safe distance in traffic.
So a system with high variability, high HRV is a good thing. It's flexible, it's resilient.
You reflect strong vagal control.
Yes.
And conversely, a low, rigid HRV is a sign of stress. It suggests the vagus nerve isn't applying that brake effectively, or that the sympathetic system is just dominating the rhythm.
And that's why HRV is often called a measure of vagal tone.
Precisely. The sources confirm that HRV primarily reflects the PNS modulation of the heart through the vagus nerve. And there are specific metrics, like RMSSD and high-frequency power, that are crucial because they isolate those very rapid beat-to-beat changes that are the unique signature of vagal activity. If those numbers drop, it's a huge red flag for what we call parasympathetic insufficiency.
Okay, so if ANS is managing our heart It must also be tightly regulating our metabolism and energy management.
Oh, absolutely. The roles here are pure resource management. When the SNS kicks in, it mobilizes stored energy. It breaks down complex fuels like glucose and fats for immediate use. That's a catabolic state.
Breaking down.
Breaking down. When the PNS is dominant, it promotes the opposite. Enablism, it's about conserving energy, promoting storage, and helping the body use its long-term resources efficiently, which includes facilitating how well your insulin works.
All right, let's move to a system where the ANS really interacts directly with disease, the immune system. This feels central to the whole thesis.
This connection is absolutely at the core of the essay. We know that an acute SNS activation, that fight-or-flight response, is pro-inflammatory, which is actually helpful if you get injured, you need that immediate response.
Right.
But the really incredible discovery is the PNS's role in actively stopping inflammation. It does this through a direct neural pathway called the cholinergic anti-inflammatory pathway, or CAP.
Okay, the CAP. How does that work? It sounds like the vagus nerve is literally talking to our immune cells.
It is. It's a brilliant neuroimmune reflex. The vagal signals travel down from the brain, and they trigger the release of acetylcholine in organs like the spleen.
The PNS neurotransmitter.
Exactly. And that acetylcholine acts directly on key immune cells, specifically on powerful inflammatory cells called macrophages. And it tells them to downregulate their inflammatory actions.
So the vagus nerve, through acetylcholine, is literally telling the immune system to stand down.
It's telling it to stand down and actively suppresses the release of some of the most potent pro-inflammatory molecules, things called cytokines like TNF-alpha, IL-1, and IL-6. It is the body's own built-in anti-inflammatory brake.
That's a game changer. So we often think of inflammation as a purely chemical problem, but the sources are framing it as a failure of the nervous system's command and control structure.
That's the core insight. If that vagal brake fails, inflammation can just run rampant. And speaking of command and control, we have to bring in the larger system that works with the ANS to manage stress, the hypothalamic pituitary adrenal axis, or HPA axis.
The HPA axis, this is the one that pumps out cortisol, the big stress hormone. Walk us through that feedback loop.
So the HPA axis is the body's main neuroendocrine stress system. A stressor, often flagged by the ANS, triggers the hypothalamus in the brain to release a hormone called CRH.
Okay.
CRH then signals the pituitary gland to release another hormone, ACTH. And finally, ACTH travels to the adrenal glands and tells them to release cortisol.
That's a cascade.
It's a cascade designed for a crisis, but it's also meant to be self-limiting.
How so?
It's designed as a negative feedback loop. Under normal conditions, as cortisol levels rise in the blood, that cortisol should signal back to the hypothalamus and the pituitary and tell them, okay, that's enough, shut it down.
But the sources suggest that under the kind of chronic stress we see in modern life, that shutdown mechanism breaks.
It does. When the system is constantly firing day after day, the receptors for cortisol in the brain can become less sensitive. They get burned out.
So the off switch stops working.
The off switch loses its efficiency. The brake fails, the gas pedal is stuck down, and the whole system spirals into this state of chronic high alert, which the sources link directly to the development of chronic disease.
Okay, so if the system is built for these acute bursts of stress followed by recovery, then our central claim is that the real hidden driver of chronic illness is the failure to recover, a state of chronic dysregulation. And the umbrella term for this is dysautonomia.
Right. Dysautonomia is the general clinical term for any condition that involves the abnormal function of the autonomic nervous system. And because the ANS touches every single system in the body, dysautonomia shows up as this incredibly diverse, seemingly unrelated cluster of symptoms.
Which is why patients often struggle for years to get a diagnosis.
Exactly. They go from specialist to specialist because it can affect your heart, your gut, your immune system, your brain, all at once.
So let's define the specific pathological state that fuels all this. It's not just stress. It's a very specific kind of imbalance.
We really need to characterize it by two interconnected things. First, sympathetic hyperactivation, which is often called sympathetic dominance. This is a state where that gas pedal is just stuck on, leading to a chronic, inappropriate elevation of your neuroadrenergic drive. You see perpetually high levels of norepinephrine.
And the second part.
The second part, which is just as important, is parasympathetic insufficiency. This is a weakened PNS, a reduced tone, characterized by decreased vagal function. And we measure it, as we said, with consistently low HRV.
So it's a double whammy. Your body is constantly getting the signal to mobilize for a threat.
And at the same time, it's losing its ability to trigger the recovery, repair, and maintenance systems.
Precisely. And the consequence of this, especially when we talk about aging, is profound. The Geroscience Review makes the central claim that this age-related autonomic imbalance directly fuels a process it calls inflammaging.
Inflammaging.
Yeah.
That's a term that perfectly encapsulates this connection. What does it actually mean? Inflammaging is the chronic, low-grade, sterile systemic inflammation that we see with aging. It's sterile because there's no active infection causing it. It's just a constant, low-level inflammatory background noise in the body.
And that's a major risk factor for almost all common age-related diseases.
A leading risk factor.
Yeah.
And the autonomic imbalance sustains this in two main ways. First, that chronic sympathetic overflow is inherently pro-inflammatory. It keeps that fire simmering.
And second,
Second, the body's own built-in anti-inflammaging strategies start to fail. The cholinergic anti-inflammatory pathway, the CAP, loses its power to suppress those cytokines. And the HPA axis negative feedback loop gets blunted, so it can't shut down the cortisol response properly. The ANS imbalance is the upstream problem that allows this inflammatory state to become chronic and destructive.
okay, this is the most critical part of the deep dive for your essay. We have to move beyond just saying there's a link. We need to show the precise physiological steps that
Yeah.
cause to mechanism to outcome structure. We've picked 4 conditions that are really well supported by the source material.
Let's do it.
Let's start with chronic inflammation and aging.
Okay, so the cause here, according to the Geroscience Review, is the progressive age-related ANS imbalance. This isn't random. It's a structural shift that happens as we get older, where you see a persistent increase in sympathetic activity and a steady decline in parasympathetic activity.
So as we age, our body's ability to put out that inflammatory fire just naturally erodes because of this nervous system shift.
Yeah.
What's the specific mechanism?
The mechanism is the impairment of those anti-inflammaging strategies, and specifically the failure of the cholinergic anti-inflammatory pathway, CAP.
The vagal brake on the immune system.
Exactly. We know it relies on the vagus nerve releasing acetylcholine to inhibit macrophages. In an aged or chronically stressed system, the CAP just loses its efficacy. It doesn't work as well.
And the result of that failure.
The result is that those macrophages are not inhibited. They just keep pumping out powerful pro-inflammatory cytokines, interleukin-1, interleukin-6, and tumor necrosis factor alpha.
So the vagus nerve can no longer send that stand down signal, and at the same time, the sympathetic system is pouring gasoline on the fire.
That's the perfect analogy. The sustained SNS overflow acts synergistically with these activated immune cells, and you get this vicious positive feedback loop that just maintains chronic systemic inflammation. And the final outcome of that is the accelerated development and progression of age-related diseases, things like cardiovascular disease and ischemic stroke. The ANS imbalance is the unifying upstream cause.
Okay, let's move from general inflammation to the heart itself, hypertension and cardiovascular disease.
Right. The cause here, what's called the neurogenic hypothesis of hypertension, is rooted firmly in that chronic imbalance. Elevated sympathetic activation coupled with reduced parasympathetic tone.
And the mechanism, the sources say it unfolds on 2 fronts.
It does. First, you have the sustained elevated sympathetic hyperactivation. Researchers can actually measure this as increased norepinephrine in the plasma. And this causes direct mechanical problems.
Like what?
Arterial stiffening and peripheral vasoconstriction. Your arteries get less flexible and your blood vessels inappropriately narrow. This sustained adrenergic drive is fundamental to the development of target organ damage and endothelial dysfunction throughout the cardiovascular system.
So that's the gas pedal problem. What about the brake pedal failure, the parasympathetic insufficiency? How do we measure that in a clinical setting?
We measure it using a really cool metric called heart rate recovery, or HRR. HRR is a validated, non-invasive index of parasympathetic function. You calculate it by measuring the difference between someone's peak heart rate during maximal exercise and their heart rate exactly 1 minute after they stop.
So it's how quickly your heart can slow down after being stressed.
Precisely. A healthy system with strong vagal tone will rapidly slow the heart down. That's a high HRR. But in hypertension, you see a reduced HRR. It's a clear pathological signature that shows the PNS brake isn't engaging properly.
And the outcome of this chronic state?
The obvious outcome is elevated resting blood pressure or hypertension. But more critically, the sources show that a reduced HRR is predictive of future cardiac events and an increased risk for both cardiovascular and all-cause mortality. It's a powerful independent risk factor.
Okay, next up, metabolic syndrome and cardiac autonomic neuropathy. Now, metabolic syndrome, that cluster of hypertension, obesity, high blood sugar, it's often seen just as a lifestyle issue. But the sources link it directly to ANS failure. What's the cause?
The cause involves all the components of metabolic syndrome, but particularly insulin resistance. And the source material suggests that this is actively facilitated by that adrenergic overdrive, that sympathetic dominance. Chronic sympathetic activation just messes up the fine-tuned metabolic balance you need for your body to handle glucose efficiently.
And the mechanism that results from this long-term metabolic strain is the development of something called cardiac autonomic neuropathy, or CAN. Let's define CAN clearly.
Cardiac autonomic neuropathy is damage to the autonomic nerves that specifically control the heart and cardiovascular system. And since neuropathy, or nerve damage, often affects the longest, thinnest nerve fibers first, the parasympathetic vagal fibers that go to the heart are often the earliest casualties of this metabolic dysfunction.
So the brake pedal wires get damaged first.
That's a great way to think about it. And the result is a profound and measurable parasympathetic insufficiency and a severely reduced heart rate variability.
The study on metabolic syndrome had some really shocking numbers on that reduction, didn't it?
It really did. It demonstrated just how severe this vagal impairment is. They looked at those specific HRV metrics that reflect vagal influence, RMSSD, and high-frequency power. And in patients with metabolic syndrome, they found these were down by 44% and 69%, respectively, compared to healthy controls.
69%. That is not a subtle shift.
No, that indicates a severe functional denervation of the PNS brake. It's a major failure.
And what's the ultimate outcome? The study connected this imbalance to something even bigger, an acceleration of the aging process itself.
Yes, this is a really compelling finding for your essay. The study calculated what they called the biological age of the participants versus their chronological age. And they found that on average, the biological age of the group with metabolic syndrome was a staggering 8.8 years older than their actual age.
Wow, so it literally makes you older on the inside.
It acts as a major factor accelerating aging. And on top of that, CAN itself is a very bad prognostic sign. It's associated with silent heart attacks, major cardiovascular events, and sadly, sudden cardiac death because the heart's regulatory system is so compromised.
Okay, our final mechanism. The link between the ANS, chronic pain, and visceral sensitivity, specifically in something like irritable bowel syndrome or IBS.
Right. The cause in many chronic pain patients, especially with functional disorders like IBS, is this generalized dysfunction in the ANS, which is linked to altered central pain processing. In the gut, this shows up as severely disrupted gut-brain signaling.
And the mechanism hinges on the vagus nerve's role in the gut.
It does. Vagal tone plays this crucial role in regulating basically everything in the gut sensitivity, secretion, motility. So when you have that autonomic imbalance, low vagal tone, plus high sympathetic activation, it leads directly to a state called visceral hypersensitivity.
Which means the gut starts perceiving normal processes like digestion as painful.
Exactly. The gut becomes hyper-responsive to normal stimuli like gas or stretching. The review on this topic actually cited evidence showing a direct negative correlation between sympathetic activity and pain intensity in IBS patients.
So the higher their sympathetic drive, the more pain they felt from the same stimulus.
Correct. It suggests the ANS is actively dialing up the volume on their pain perception. On top of that, low PNS activity means the digestive system loses its rest and digest function. You get decreased GI motility, which leads to symptoms like chronic constipation, a classic sign of dysautonomia.
So the ANS imbalance is responsible for both the physical dysfunction and the perception of suffering. The outcome then is the development of these functional GI disorders like IBS, defined by that hypersensitivity, disturbed motility, and chronic pain.
Correct.
We've laid out some pretty overwhelming evidence that ANS dysregulation isn't just a side effect, it's a primary mechanism of pathology. This seems to demand a shift in how we approach treatment.
A fundamental shift. Autonomic balance has to become a primary therapeutic target, not just some adjunctive add-on therapy.
And the strategy is all about shifting the body's set point away from that chronic sympathetic state.
The whole goal is to achieve vagal dominance as a tonic or baseline state. And we can do that through a combination of behavioral and pharmacological methods.
Okay, let's start with the most accessible and powerful behavioral tool the sources highlight, breathing techniques. Specifically, what the research calls respiratory vagal nerve stimulation, or RVNS.
Right. Contemplative practices like meditation and yoga are so effective because they all, in one way or another, emphasize a specific breathing pattern, slow respiration, with a particularly long exhalation.
And that's the mechanism, the slow exhale.
That slow exhale is the mechanism. That specific rhythm, which studies suggest is optimally around 6 breaths per minute, directly and voluntarily stimulates the vagus nerve, that is RVNS.
Why that specific rate, 6 breaths per minute? Is there a physiological reason?
There is. That rate is what's called your resonance frequency. At that frequency, your heart rate variability syncs up perfectly with your breathing cycle. And this dramatically strengthens something called your baroreflex sensitivity.
The baroflex, that's the reflex that manages our blood pressure, right?
Yes. And when you strengthen it, you get more frequent, more robust vagal reflexes. Each breath cycle creates this momentary surge in PNS activity, which immediately lowers your heart rate and blood pressure.
And the long-term benefit of doing that over and over.
The long-term physiological shift is that this repeated high-intensity vagal signaling induces a beneficial long-term tonic shift toward vagal dominance. Techniques like HRV biofeedback use this principle, often with real-time monitoring, specifically to enhance vagal activity and, by extension, strengthen that cholinergic anti-inflammatory pathway to help suppress those pro-inflammatory cytokines. It's direct neuromodulation using your breath.
Okay, next step, the foundational importance of physical activity and exercise.
Regular aerobic exercise is one of the most well-established non-drug methods for activating the vagus nerve. The main mechanism is that training leads to a lower baseline blood pressure and a beneficial shift in your overall autonomic tone.
And the physiological change is measurable.
Very measurable. Exercise significantly increases PNS function, and we see that in marked improvements in heart rate recovery, HRR. And we already know that HRR is independently predictive of successful blood pressure reduction. Basically, exercise trains that vagal brake to engage faster and harder after any kind of stress.
Now, this is a critical point for a high-scoring essay. While exercise is vital, we have to include the caution about patients with severe dysautonomia.
Oh, that distinction is absolutely non-negotiable for a balanced argument. For patients with severe dysautonomia, like you see in chronic fatigue syndrome or post-treatment Lyme disease, they often suffer from profound exercise intolerance.
And post-exertional malaise, or PE.
Exactly. A complete collapse of function that can happen 24 to 48 hours after even mild activity. For these individuals, intense exercise is not just unhelpful, it's counterproductive and can make their condition much worse.
So the strategy has to be completely different.
Completely different. Treatment requires highly specialized, gentle movements, pacing, and often exercises done lying down or sitting to minimize that orthostatic challenge. The goal shifts from maximizing fitness to simply optimizing stability.
Okay, finally, let's talk about targeted pharmacological agents. How can we chemically nudge the ANS back into balance?
We have two main approaches here.
Yeah.
Either enhance the brake or inhibit the gas.
Let's start with enhancing the brake.
To do that, we use vagomimetic drugs which enhance the PNS. A common example is pyridostigmine. It's what's known as an acetylcholine esterase inhibitor.
So it inhibits the enzyme that breaks down acetylcholine.
Exactly. The mechanism is simple, but very effective. By blocking the enzyme that clears acetylcholine away, you increase the concentration of that neurotransmitter, which amplifies and prolongs the PNS signal.
And the clinical result of boosting that signal.
The physiological shift is improved cardiovascular dysautonomia. It's very useful for conditions like POTS, and it can also increase colonic motility, which is an effective treatment for the chronic constipation that so many of these patients suffer from.
Okay, so that's boosting the brake. What about inhibiting the gas pedal, the sympathetic overflow?
For that, we use sympatholytic drugs. These include classic agents like beta blockers, such as propranolol.
How do they work?
Beta blockers specifically inhibit what are called beta-1 adrenergic receptors, which reduces that sympathetic overactivity. They're very effective for managing symptoms like a racing heart or palpitations. They just lower the heart rate and reduce that sympathetic nerve traffic.
And they're newer agents, too.
Yes. Drugs like ivabradine are really useful because they are more targeted. They selectively inhibit what are called the funny channels right in the heart's pacemaker node, so they reduce heart rate without the systemic side effects like lowering blood pressure that you can sometimes get with beta blockers. These drugs give us a way to manually restore that sympathothovagal balance.
This has been a true deep dive. We've really established that chronic ANS imbalance is a powerful, unifying way to explain so many chronic diseases. So what's the ultimate message for your essay's conclusion?
I think the strength of this framework is that it provides this elegant explanation for how chronic stress and aging can act as these unifying upstream drivers across so many seemingly unrelated diseases, CVD, gut pain, metabolic disorders. It moves the focus from just treating the symptoms in a specific organ to restoring the body's fundamental master regulator.
But for a balanced critique, what's the key limitation we have to acknowledge?
While ANS dysregulation is clearly pivotal, we have to acknowledge that organ-specific pathology still matters. But the biggest limitation, which the review on chronic pain really highlighted, is a lack of standardized measurement protocols in the clinic.
So different researchers are measuring it in different ways.
Exactly. Until the non-invasive measurement of vagal tone using metrics like HRV is consistently applied across clinics and research, drawing clear causal conclusions for every single chronic condition remains a challenge.
And that leads us to the final provocative thought for you to explore as you write.
The ongoing challenge, and I think really the future of integrative medicine, is standardizing these high-fidelity, non-invasive measurements of vagal tone using reliable metrics like HRV and HRR. If we can do that, we can guide truly personalized targeted treatments. If we can consistently measure the specific defect in the homeostatic balance, we can finally move beyond just generalized symptom management and actually treat the body's control system itself.
All right, let's make sure you walk away with the perfect blueprint for that high-scoring essay. We'll start with the thesis statement.
Okay, your concise thesis statement should be something like this. Chronic autonomic nervous system imbalance, specifically prolonged sympathetic hyperactivation and concomitant parasympathetic insufficiency, acts as a unifying upstream driver linking modern stressors and aging to the pathological progression of diverse non-communicable diseases, requiring therapeutic strategies centered on restoring homeostatic sympathobulbar balance.
Excellent. And here is the logical essay outline you should follow. Make each of these points a deep, evidence-based paragraph.
Okay. 1. Introduction. Define the ANS, SNS, PNS, homeostasis, and don't forget the enteric nervous system. Then state your thesis clearly.
2.
2. The core pathology. Define dysautonomia, sympathetic hyperactivation, and parasympathetic insufficiency. Explain how this imbalance fuels inflammaging, and detail the failure of the body's anti-inflammatory strategies, CAP and the HPA axis.
Then the 4 mechanisms.
Right. Paragraph 3 will be Mechanism 1, ANS and chronic inflammation aging. Use that cause mechanism outcome structure, focusing on the breakdown of the CAP and cytokine release. 4. Mechanism 2, ANS and cardiovascular disease hypertension. Focus on SNS vasoconstriction and the pathology shown by reduced heart rate recovery, or HRR. 5. Mechanism 3, ANS and metabolic syndrome. Define cardiac autonomic neuropathy and cite that significant HRV reduction in the 8.8-year difference in biological age. And 6. Mechanism 4, ANS and GI chronic pain. Explain vagal control of motility and how sympathetic hyperactivation increases visceral hypersensitivity.
And the treatments.
Paragraph 7. Treatment implications. Argue for autonomic balance as a primary target. Explain behavioral neuromodulation, the RVNS, 6 breaths per minute, the Burrowflex, and physical activity, including that critical caution about exercise intolerance. Then cover the pharmacology.
Sympatholytics and vagamimetics.
And finally, the conclusion.
8. Conclusion. Review the ANS as a unifying driver, weigh it against the limitation of non-standardized measurement, and reiterate the need for targeted balance restoration. Perfect. Finally, let's help you avoid some common traps. Here are the common mistakes to avoid.
First, do not moralize sympathetic activity. The SNS is essential for acute survival. The pathology is chronic hyperactivation and the failure of the PNS brake to engage. Don't frame it as good versus bad.
Good point. What else?
Avoid oversimplifying vagal tone. Always frame it as a quantifiable, measurable index of parasympathetic function. Use the specific metrics like HRV or HRR. Don't just talk about it as some abstract feeling.
And the most important one.
Ensure your mechanisms are explained. Don't just list associations. You have to explicitly link the autonomic failure to the physiological change. So link CFP failure to cytokine release, or link SNS activation to changes in vascular tone and hypertension. Show, don't just tell.
And for quick reference, here's your brief evidence map to anchor your claims.
For general ANS definitions, you'll want autonomic dysfunction stat pearls. For inflammation, aging, and the CAP, the geroscience review is key.
What about for the specific conditions?
For HRV and metabolic syndrome, use the HRV in metabolic syndrome study. For hypertension and HRR, it's the effects on blood pressure study.
And treatments.
For breathing and RVNS, it's the breath of life review. And for pharmacology and general treatment strategies, the dysautonomia review and the pharmacological modulation paper are your go-tos. You now have everything. You have the detailed physiological knowledge, the structure, and the evidence map you need to confidently build a high-scoring essay that hits every single part of this complex prompt.
That wraps up this deep dive. Go crush that exam, and thanks for trusting us with your source material.